Hello, everybody. This is another episode of Artificial Intelligence and Cybersurgery. I'm Dr. Andrew Gums. I'm here with my co-host, Dr. Vincent Grasso, or also Professor Grasso. And we're here with an entire team from Serbia, from Belgrade. We're going to be talking first with Professor Dejan Radenkovic. He's going to be introducing his two collaborators because we're actually starting a project to collect data to essentially be able to do an AI-powered tumor board. That project is called ERGOS, which stands for Artificial Intelligence, Radiomics, Genomics, Oncopathomics, and Surgeomics. And we're going to talk a little bit about that. And we have some good news to report. We found a company that is going to help us store data in the cloud. We've identified 8 centers around Europe, which we'll also talk about. But without further ado, Vincent, please, if you could introduce our next guest a little bit better than I just did.
No, you did a great job. It's exciting. I think this is the first podcast where we have a group of guests from one location. So that's going to be really interesting for our viewing audience. We're at episode 69, which is fun. And Professor Radenovic is professor of surgery and head of HPB at the University of Belgrade. He has his colleagues on that he'll introduce. So welcome to our podcast. And Doctor, if you could introduce yourself a little better and your guests, we can get going.
Okay, thank you very much. It's my great pleasure and honor to participate in this type of podcast. And to be honest, this is my first time that I'm in this project, something like this. So I'm so happy because I'm interested for innovative things which can happen. So I am the head of one of the HVB departments, University Clinic for Digestive Surgery in Belgrade, which is connected to medical faculty, University of Belgrade. And we are mainly doing the HVB surgery. So that means half liver and half pancreas surgery. I'm more pancreas guy, and I have two guys who's doing more liver things. So here is one of my coworkers. He's our young surgeon who 1 year ago finished his residency, and mainly he was on HVB department due to the organization in Serbia. That means that after the 2 years of residency, you are on some type of, let's say, fellowship. That means that you are subspecialist and you spend the time on department in the field of surgery which you would like to continue. So he's a general surgeon, but with a lot of interest for HPV surgery, and he spent most of his training in HPV department. And also our friend from radiological department from my hospital, assistant professor Dusan Shaponsky, who is one of the leaders of the young radiologists in our country. He's in the moment president of Young Radiologist Association in Serbia. So, and he's working with us in Digestive Surgical Clinic. So they are our part of the team and our big support in all things what we are doing. Because as you know, we can't do anything in surgery nowadays without very precise diagnostic. So I'm happy to have both of them here. And I think that when I spoke with Andrew during our HVB meeting, European HVB meeting in Dublin, that maybe we as a team or as a clinic can join you and join your project. And so we are happy to see what's going on and what will be the further steps.
Yeah, it's really an exciting time because I met Professor Radenkovic for the first time in Dublin, as he mentioned, at the European and African Hepatic, Pancreatic, and Biliary Association, and we had a lot of common interests. And I was explaining to him, I think I had given maybe a presentation on Ergos, which essentially what we want to do is we want to collect data, specifically, clinical data, preoperative clinical data, obviously long-term follow-up data, lab values, BMI, patient sex, ASA, all the usual suspects. But we also want to collect the last preoperative CT scan. We're going to use pancreatic cancer as kind of the first test case. We're going to get the CT scan within 1 month prior to the surgery. We're going to upload images on the cloud. We found a company that has agreed to do this. They've already set up a platform for us, actually. And we're going to mix clinical data with radiomic data, and then we're also going to mix it with pathomic data. So we're going to look at the voxels, the three-dimensional voxels from the CT scan to get information on the kind of the biology of the tumor. But then we're going to use two-dimensional information, the pixels from the pathology slides, and we're going to try to combine them and see, what further information we can get. Ultimately, the next step, so you understand, will then be to combine this information with genomic data. Okay, so what we're going to do is do whole genomic sequencing and combine that, prospectively, so we can get an even more powerful information. What we want to do is get real-time decision support. So say you have a patient with a solitary metastasis from pancreatic cancer. Maybe with all the information we have, we can find out that that patient has good biology, actually, and it makes sense to do the Whipple and the liver resection or the liver ablation. Or we have a patient with, a borderline resectable, and we need to do an Appleby. We need to resect the hepatic artery. We want to get that type of real-time decision support. That's the ultimate goal. Obviously, we're years away from that, but we have to start somewhere, which is why this is such an interesting initiative. We have 2 centers in Belgium, 2 centers in Italy, 1 center in Germany, 1 center in Poland, and obviously you guys in Serbia. I feel like I'm missing a country, but you get the idea. We have multiple centers, and we're gonna start to we have computer scientists from Scotland who's part of our editorial board of artificial intelligence surgery, who's agreed to help us with the algorithm. And once we collect about 200 patients, I already have an investor who's going to help take it to the next level. And so that's really what we're trying to do here. So Dusan, can I ask you a question from the radiology perspective?
Oh no, I'm here. Just a second.
Yeah.
So I was.
Well, let me ask you my question. So
let me just say this firstly, because I was doing something like that. I was few times in AKH in Vienna for a couple of months. So with some of my friends, we tried something similar. We did segmentation of pancreatic cancer and normal pancreas tissue with the pathohistology report, adenocarcinoma. So just so we can just with machine learning and segmentation to be sure that something's adenocarcinoma, not mucinous component, nothing else, nothing IPMN with some presentation, just adenocarcinoma, just to be pathohistology proven. And we have really got good results. But then the machine learning was going to improve, and we waited for something more. And of course, we didn't do anything with that. But that's the good idea. We can do a lot of that with CT segmentation and pathology.
So yeah, no, absolutely. I think, but the interesting thing is that the hardest part of this whole project seems to be able to share information across countries, across institutions, but also patient privacy. So there are programs I've found online where we can de-identify DICOM images. Are you familiar with some of these? Do you know how to de-identify the image before you can?
Yeah. I'm also like the CFO of one company, Telmed. They're doing teleradiology. We're now trying to do for Africa to do their reports and like teleradiology for all Africa continent. So we have a lot of engineers IT that doing that part of the project.
Well, that's fantastic, because what we're going to need you to do is to get the preoperative CT scan and de-identify it, and then upload it to the cloud. I will share it with Professor Radenkovic.
Do we have that possibility, Dusan? Do we have that possibility to de-identify the data?
Yes, so we can export it like anonymized, without name, without any part of the name and everything, with every patient.
If I get you well, for example, starting from day one, we have the patient, for example, with pancreas cancer and liver mets, and then we're doing the CT scan or the MRI or both. Is it important to have both, or it's better to have the both?
If we have both, we'll upload both. Um,
Okay, then we will upload what you need more to upload the pathophysiological report.
so what we need, not just the histopathology report, we want the actual pictures of the slides. So,
Pictures from the slides. Okay,
yes,
digital pictures.
exactly,
Or it's
exactly.
or it's enough to have it via phone.
Well, believe it or not, for like $100, you can buy something that attaches to your iPhone, and you can then just sit there and take pictures of them and upload them that way, or you can put them on a scanner and upload them that way. These are the type of things that actually we're going to figure out. Every hospital is going to have a different solution. So we don't necessarily want the data to arrive to us in the same way, because actually the more heterogeneous the data is, kind of the better and stronger the algorithm will be. So we're gonna figure that out together, how you're gonna get us your slides. Maybe the pathologists already have digitization of their slides.
You
Maybe
know,
another university does, and they'll help us, solve your problem in Serbia. That's gonna be another step that we have to cross.
yeah, but you need the clinical data from the patients as much as possible. That means BMI, CA99, and all this clinical
Exactly.
data,
Yeah.
and that's enough for beginning.
Exactly, exactly. And in the beginning, I just want retrospective data. I just want patients over the last 5 years. And then just so we have some information that we can give to the computer scientists to begin the algorithm.
Yeah, but you have to just because we have some data for sure, but from pathological side, it can be it's device which you can put in your phone, and then it can be. I haven't heard for the device where we can buy it.
Exactly, exactly. And then you take the picture of the slide itself, and it records a digital image that you can then upload to the site that I'll give you access to. I think they might have
Yeah.
sent you an email already.
No, I didn't receive it.
Okay. Oh, it's true. I have to sign the contract with them first, and then they'll probably send it to you then.
Yeah,
And we're
but
gonna
also
probably, just so you know, we're gonna probably, I'm thinking of starting the data collection probably in maybe January 1st. We might do it sooner, but I think by the time we get everything up and running, because I'll be very honest, we have the company I'm working with is they're going to give us 1 year free of data storage. So I think it might be better to start January. We might move it up a few months. We'll figure that out.
yeah, and also we need to pass the ethical approval. We
Yes.
need
So the University of Ghent has already started an IRB approval process. So once we get their approval, we're going to give it to everybody else, to get approved.
Yeah, but we need to have some project. We need to have some study or something because we can in Serbia we can apply for ethical approval just with some project or study or whatever. So we need to have outlined something.
Yeah, yeah. We'll hopefully have something for you by September that you can submit.
Yeah, because if you have that documentation for the Ghent, then you can send us that. There's maybe it will be enough.
Absolutely. They're drafting it now. I gave them an old grant of mine, and so they're now fine tuning it so it fits for an IRB.
Okay, when you will have that data, that papers, which can be it should be study. We will call it study or trial or whatever, but something like that. We have to apply with something which that we are part of multi-center study regarding the AI, and I think Peja will not have big problem in ethical approval.
Yeah,
Yes, yes.
yeah. That's why I think January 1, 2026 is going to be realistic to start collecting all this data.
Okay, but you think that first we can start with retrospective data collection.
Absolutely. We're just going to keep it simple, create, just kind of prove the concept, that we can create an algorithm. And then once we can, that'll be kind of our training set. And then going forward, once we get funding, we're gonna collect prospective data to kind of test our training
Yeah.
algorithm to see if it works even. to see if it
Okay,
gives us any
if
clinical
I can
benefit.
tell, you need MRI because we can start collecting data starting from now, or I don't know, Dusan, how long you keep the MRIs and CTs? I think for 3 months.
Maybe a little more, but we can export it on some other memory so we can save it. We can start from even
Yeah,
today
yeah,
exporting and
because
waiting for approval of ethical board.
because we have a bunch of patients, really. So we can have if you need a liver and pancreas,
Well,
a
I'll tell you
liver
the
tumor
second.
or pancreas tumor or both.
Well, we're going to do first pancreatic cancer, then we're going to do.
Yeah, I would start with one illness and one diagnostic method. Some, for example, with pancreatic cancer and with CT, not with two of them for the beginning. I think it's a better idea.
Exactly. We're going
Yeah.
to keep it as simple as possible. Just the preoperative CT scan, and then I'm gonna try to get you maybe access to this. Maybe I can get you access to this website sooner, Predrag, so you can start uploading things. But I have to kind of think about that when we actually going to start doing it.
We can't upload before the ERB before the ethical approval.
Yeah, you know what I'll do? I'll just give you a blank Excel with all the things that we're looking for, just so you
Yeah.
have an idea of what we're looking
Okay.
for.
Yeah, great.
Okay.
Okay.
So because
So
I
it's
think
something like
that
template, right?
Yeah, in Excel, there's like, I think they were looking at 30 things, something like that.
because, for example, for the last 3 months plus additional 4 months before we are starting, we can have, I can say, with all type of metastatic and inoperable, so we can have around 100 patients. You told me that your first cohort is planned to have around 200.
Yeah, so I'm trying to, I would like ideally get about 30, 25 cases from each center. And like I said, we have about 8 centers right now.
So it will, for our side, it will not be a problem at all to have it until 1st of January, all of these things. And
Yeah.
tell me, if we are doing the percutaneous biopsy, it will be fine also as diagnosis for this pathophysiological report.
That is a good question. And ideally, in the beginning, that will be enough. So we either want preoperative, a needle, or postoperative. Ideally, we would get both.
Yeah, because for the patient with metastatic disease or for the locally advanced, we will not have the operative pathology.
Well, yeah, what we want ideally is patients that have surgery. We want patients that underwent resection, ideally.
Ideally, okay. But I think if we have 25, we can collect it for the last. Dusan, I think for the last three 4 months we will have the patient retrospective
Yeah,
also.
yeah, definitely.
Yeah, I
So
mean,
for the beginning, you need 25 patients from our side. That's it.
exactly. Just
Approximately.
exactly. Obviously, I think that's what our goal is from each center now. I don't want to overburden people, and then we'll kind of reassess. But for now, 25. I think we're going to write something like 20 to 50 per center, but.
Okay, I think that it's doable for us. It's easily doable.
Good.
So we need pathophysiology, we need resection. That's it, and mainly exclusively to pancreas cancer.
Yes, we're going to start with pancreas cancer, then we're going to do colorectal metastasis, and then to the liver, and then we're going to do hepatocellular cancer. But I think again, not to burden everybody and not to like make everybody go crazy. We'll start just with pancreatic cancer.
Okay, it will be nice if you as soon as possible to send us that Excel sheet to see which data do we need it, and I think that up to the 1st of January we can have an update.
Good. We look forward to it. So I think.
Dusan, do you see any problems?
No. Just to see Excel table to see what we need and to get ethical approval, we can start.
Great. I guess it would be also good to maybe talk to your pathologist. The reason I say that is one of our centers, they're having a little bit of a problem with their pathologist. Their pathologist is very controlling of data. So not every situation is created equally. So I would just make sure you talk with the pathologist just to make sure that they will not block, usage of their images.
I don't experience such type of problem, but you never know. I will check it.
Yeah, what's what I'm looking for? You're clearly, anyway, that's a good thing. You don't have that
But I don't
problem.
know. I cannot guarantee, but I haven't experienced, because in our country you can take every patient can take their own blocks
Yeah.
and go for the second opinion. So if we take the blocks for second opinion, we can do whatever we want.
No,
with this.
the reason I was smiling is I was thinking to myself that Serbia sounds like it was in the old days where the surgeon is still king. And that's why I was smiling. It reminds
Yeah,
reminded
it looks like. No, you're completely right. Therefore, I told you that we can do it much easily than in other countries.
Yes, yes. So Vincent, how does the project sound to you so far? Are we on the right path?
Yeah, it sounds very exciting, especially that you have collaborators with expertise like Dusan, and then you have a radiologist that understands how to collect data, and he's business minded. And as we've experienced, if you try to do something like this in a big giant university center in the U.S., it'd be very very hard, right, to get a big academic center to give you access to all this data. So it's fortunate that you have collaborators in Serbia and elsewhere that are willing to participate in a very exciting study like this.
Yeah, because I'm actually thinking, Dusan, some of the other centers might have to um, contact you to help them de-identify DICOM images before they send. I don't know. Maybe they'll have to use your company. I don't know how that's going to
Okay.
play out.
Okay. We can make a deal. We can make agreement. We'll see. Let's
Sure.
start from the beginning, so to see how it's going, and then we will make every issue disappear.
Yeah,
Great, great.
and Andrew, can you make me more clear about this device, which how I can make digital photos of the pathology?
Yeah, I will. I'll send you some Google images.
Okay.
Honestly, I haven't used this device myself. The way we're going to collect images is the pathologist where I'm going to be collecting data. They already digitized the images, so it's easy for me. But I saw, just on I think eBay or Amazon that they have these devices for a few $100s. You attach to your phone, and you can take pictures of the slides, and they'll be digitized. But I'll send
Okay.
it to you.
Or I'll ask them whether there will. I think, as far as I know, that they are not able in our lab to do that digital. I think they don't have digital photos,
I think
but
the
I will
easiest
check it.
would be to buy a scanner. I think you can buy a scanner for Vincent. How much is a scanner? $200, $150?
Yeah, they have flatbed scanners that have a cartridge for slides, and
Yeah.
they're very inexpensive. So that's a desktop, nice,
It might be even
couple
Professor,
hundred.
yeah.
I think I have that device at my home that Dr. Andrew is talking about. It's
Okay.
like an iPhone add-on, so you can put it and take photos with a lot of zoom in.
Exactly, exactly. But anyway, I'll
Yes,
send
my
you
wife.
a scanner and I'll send you this other thing I'm talking about for the iPhone. Okay?
Okay, perfect. We will check it. We will check
Sure.
it, but I think that from my point of view, it will not be some hard project for beginning. We just need, because we have from a radiology guy, from our side, just from pathologist, and I think that everything will be in the circle. So also, I think that we will easily pass ethical committee. So I don't see any real issues.
Perfect, perfect. Yeah, I'm actually currently completing my MBA, so I've really embraced the concept of the MVP, the minimal viable product. So I finally have Ergos down to its essence of what we need so that we can take the next step forward. So Vincent, I'll let you close this out. Looks like we only have 5 minutes left.
Yeah, this is a very exciting podcast. I mean, it was our first podcast with an audience, a group, and on a specific
Yeah.
topic. So this is exciting. So closing up episode 69, right, Andrew? I think we're at for our AI and Cybersurgery podcast.
Yeah.
Gentlemen, thank you so much for your involvement. We'll get back in touch and follow up on this exciting discussion.
Yeah.
And wishing you all well.
Great.
Okay,
Thanks a lot, everybody.
it was my pleasure to be part of it. So thank you, guys.
All right.
Yeah,
Thank you.
mine too. Thank you for everything.
Take care, brother. Take care, Dusan.
Thank you.
Bye.
Bye. Thank you.